Thank you for joining me. So, my first question for you is, what are some misconceptions that you would love to clear up about independent practice urology and working in this industry?
Yeah, thank you very much. I do think there's a bit of a misconception about what it is to work in a large urology group and what our real goals are. I think the great thing about being in a large urology group is that we can affect the health and the lives of so many patients, and it's really what we are all dedicated to. There's this concept that somehow an independent practice is more concerned about finances than they are about the health of our patients and the care that we're providing. And it's really not at all true. We certainly are responsible for some of that, for our doctors and our staff and our patients. We need to be able to continue to work to take care of them. But the focus is always on what is the best care of the patients. And certainly then we try to make a business case around it. So, I think the misconception is that somehow that financial discussion creeps into the healthcare discussion. It really doesn't. I think it's just a different model. And I think what you've seen in recent years is, using sort of the academic world as a comparison. The academic world has had to become a lot more aware of the financial impact of their care, and oftentimes the providers are being required to hit certain financial marks, whereas in independent practice, we've been becoming much more sophisticated and specialized and being able to put things together that are almost what traditionally would have been thought of as an academic model. So I think the misconception is that somehow we're fundamentally different in how we try to approach what we do every day. And I really think it's actually been extremely rewarding to be a part of an independent practice that's forward thinking and looking to always do what we can for our patients.
Great. So, what made you pursue independent urology instead of working for a large hospital?
So when I was deciding where to go to work, it was a number of different factors. I think the primary one was my wife was from Maryland, and I knew we were coming back here. I did my fellowship in my own hometown of New Orleans, and certainly was considering academic, employed, and independent options. I had gotten to know some of my now partners during my residency in the community and rotating with them as a resident. So it was a fairly easy decision for me because I saw that possibility of providing in an independent group. I never really considered strongly going into an employed model. It's kind of exactly what I don't want from going to work for a hospital. So it was really between academics and independent practice for me. But I'm really happy with the choice that I made.
Awesome. So, just kind of piggybacking off of that, are there some things that you wish you did do differently when you started your career in independent practice?
I think when everyone's starting out, there are always things looking back that you could have done differently. Early on, I think the feeling was, and I think this is very natural, is all I was really thinking about was using what I did during my fellowship, and or what my interest was. For those people that don't do fellowships, what your primary interest was. And it became clear very quickly that everyone in our practice to some extent is a general urologist. I think that is important for everybody to be connected to the world of general urology, and your specialty grows. So I do think there's always a little bit of impatience early on. I think that's natural looking back. But at the same time, I think there was that drive and that understanding of what did I really enjoy most about urology, and finding a way to make sure that continued to be a big part and a growing part of what I wanted to do. But I think, it's not really a strong regret. It's just more that when you look back, you say, okay, I get, where I was then and where I am now, and the time that it took to get there.
Right. So, now you're at Chesapeake Urology, and I'm hearing that you guys do some really, really important research and clinical trials. So, what's one of the most impactful research projects that you've worked on so far?
Yeah, so working in clinical research in an independent practice was not necessarily something I knew I wanted to do. But as my clinical practice became a little bit more specialized, especially in the realm of advanced prostate cancer, this whole new world was really opened up to me. I'm very fortunate to work in a practice that had an existing research group led by one of my partners, Ron Tutrone, who really has been dedicated to this for a long time. And it immediately became apparent that there was just a whole lot of options available to to partner with industry to bring new treatments to our patients during development. So one of the more recent trials that I think also shows the real strength of an independent group, and given the volume of patients we see, that meshes very well with improved clinical care of our patients, is we are part of the ProVent trial, which was a large trial looking in the in the active surveillance population in the use of ProVent or Sapulacel T. So this was something that would be very difficult to do in an academic practice where, frankly, it's probably a little bit more hit or miss as far as how much active surveillance you have, and also because the infusion practices are often separated from the urology practice, right? Infusion tends to live in oncology in an academic center. So the fact that we already were doing a fair amount of infusions, we had that facility, we had a robust research group, and we were very up on best care in using active surveillance, it allowed for us to very quickly recruit a good number of patients into that trial, which we're still following those patients now to see what the outcome is. It was very rewarding just to have that ability to sort of, leverage everything that we provide across the clinical spectrum and be a part of advancing healthcare, advancing the care for our patients. So I think it was a nice combination of everything. And along those lines now, we see a number of trials that we're able to be a part of that are incorporating specific biomarkers into advanced disease. We see a lot of the advanced treatments gradually working their way back into the earlier stages of disease, where there's no question that we have the strongest association with the patients, the largest number of patients. So if we can find the patients and offer them a potentially targeted treatment earlier in their disease or even after they've failed other treatments, it's very rewarding to be able to be a part of that. And as we've seen, it's also then leads to our early ability to use those treatments once they're approved because we're already comfortable with them.
Great. So that said, where do you see infusion treatment, where do you see that sort of evolving, or what do you see it as in the next 10 years, how that will all shake out with these clinical trials and things?
I think the term infusion therapy is a good one because it includes a lot of different options, right? We used to think of infusion centers as primarily for cytotoxic chemotherapy, and that's why they were associated with a lot of cancer centers and the like. But there's so many therapies now that are provided through an infusion technique, and granted, you need the equipment, the setting, and the nursing to be able to do it. But the treatments themselves are often more targeted or in an earlier phase of the disease that we're very comfortable taking care of. And I think Keytruda is a PD-L1 inhibitor in the bladder cancer space is one of our first exposures to that. Certainly, we also have therapies from radiopharmaceuticals and immunotherapies that we are currently giving. I only see this as expanding, and as we get into more targeted therapies, as we get more of an understanding of the underlying biology of these individual cancers in each patient, we're going to have more and more options. And I think this is where the research component, the infusion component, and just the broad patient care aspect and the large number of patients we take care of all really comes together to hopefully provide an ideal setting for delivery of care, for research, et cetera.
Last thing about some of the stuff you guys are doing at Chesapeake Urology. What's one of the coolest or latest or most cutting edge innovation that you guys that you have at your practice that you're most proud of?
So we try to stay at the cutting edge of a number of things. And my focus certainly is on prostate cancer. That's my main role from a clinical leadership standpoint. I also am, though, very proud of what we're doing across other disease states. We followed a model of identifying patients for advanced prostate cancer early on, and that's helped us really make sure that across the practice that we're able to identify and offer therapies to a large number of patients. We're now being able to apply that in bladder cancer, where there's really a nice kind of, nice might not be the right word, but there's at this moment in time, there's a coalescence of a lot of different factors that make getting really well organized around bladder cancer that much more important. And some of it's driven by something as simple as the shortage of BCG availability across the country. It kind of forces us to be more critical of how we're using it, which allows us to get a little more insight to the practices across our group, and how people individually are taking care of bladder cancer. And at the same time, we know that there are emerging therapies, both in research with PD-L1 inhibitors and other things coming down the line that are going to allow us to better treat those patients. So I'm actually really proud that we're sort of taking this model that we've developed over time for one disease state and working in others. We're also doing similar things in voiding symptoms and BPH and overactive bladder to try to identify where we have patients that we might be able to provide a higher level of care to. So I think it's that what excites me the most is that our team, our docs, are bought into this idea. They've seen it work. They don't view it as an enemy, right? I think some people might say, oh, geez, are you looking over my shoulder? It's not that. It's really that, okay, we can't expect every doctor to be up completely on everything. We've invested, a lot of our experts have invested a lot of time and energy to staying on top of things, but even they can't see all the patients that we have in our practice. So it's this ability that we've found to partner with the expertise we have in-house to elevate the care across the board that really excites me for what we're doing and what we hopefully can do in the future.
When you are sort of running this advanced cancer care clinic, is it stressful? Is it fulfilling? Does the impact outweigh the stress of running the show? Like how does that affect you on a personal level?
So I do think that playing a leadership role on the clinical side is extremely rewarding. It does bring on new levels of stress. I think some of it is very personal. I'm never been one to be able to stay completely content when I'm very focused on one thing. I like to use multiple sides of my brain. So being able to be involved somewhat on the organizational side, on the operational side, and frankly, even on the business side a little bit, in helping frame and develop the clinical programs and expand them and find ways to continue to work. It's very, very rewarding for me on a personal level. I think it's opened up a whole new world to me in relationships with docs around the country, with some of our industry partners, and frankly, even within our group with the different administrators and doctors that I'm able to get closer to and play a really a critical role in developing something that I think is extremely important. Because at its heart, this is about trying to reach all of our patients. And when you're talking about hundreds of thousands of patients coming through the doors of our different practices, it's really critical that we continue to innovate and continue to be a part of this. So it is very rewarding for me to be a big part of that.
How do you manage your time now with doing all of this work and also continuing to be a physician, being a husband, et cetera? How do you manage your time?
So time management is something that is always, I think, an ongoing struggle. I don't think that's unique to me or to someone who does a hybrid of administrative and clinical work. I think all of our doctors struggle with that. Balancing family life and work life is always a challenge. I'm very fortunate to have a very supportive family at home. I think we leverage technology a lot. So instead of, flying out to meet with somebody like we might have done before, the time that we live in is opened this door towards more remote meetings, which has saved a lot of time, to be very frank. But I also have a very supportive group that recognize that this is something that benefits the whole group. So I've been able to scale back on some of what I see and become a little bit more specialized. It has meant on some levels a sacrifice for me because I've given up seeing a lot of the diseases that the patients with diseases that I took care of before, giving up certain types of surgeries and certain types of patients that I might have been sent for consultation before. It does mean I'm given a little bit more free time not free time, but time to do the administrative work in addition to the clinical work. But that balance is always a struggle. I feel, this really is, when you're talking about the administrative work of helping within groups, as well as the clinical work of being a doctor, neither of these are really part-time jobs. So at times you feel like, you're doing, even if you're 50-50, supposedly you're really kind of 80% of each, because there's always something happening clinically and there's always something happening with the practice that needs attention. So I it's just put one foot in front of the other, take care of one crisis as it comes. But I think in the end, I'm enjoying it and finding the time to be with my family. I have a 10-year-old and a 7-year-old kid. So they're still the most important part. And I'm there, as much as I can when they're dropping them off at school and picking them up and being there in the evening. But there are times when I'm away. So it's just sort of embracing each moment for what it is and taking full advantage of it.
Love talking to you. We could talk for the rest of the day, but I know you're super busy. So
Thank you,
so
Summer.
much.
I appreciate it. This was easy. I appreciate you following up with me.
Thanks. Bye.
All right, bye.